Hello, and welcome to the Clinical Care Options Infectious Disease Podcast. I'm your host, Sarah Anderson. This podcast is the second of 3 installations in the program, Optimizing Outcomes in Older Patients with HBV. During this podcast, Professor Graham Foster, Professor of Hepatology at Queen Mary University in London, United Kingdom, discusses the interplay of comorbidities, comedications, and adherence in the management of older adults with hepatitis B. For more information about Professor Foster and for a link to the full online educational program, please visit the link in the show notes for this episode. Now, let's get started and hear what Professor Foster has to say about managing older patients with chronic hepatitis B.
Today we're going to talk a little bit about treating hepatitis B in the context of the older patient. Now let me be clear that old in the context of hepatitis B means people over the age of 40. It does not mean the very elderly and the very infirm. Because what we know about hepatitis B is that once people are over the age of 40, things start to change a little bit. The risk of malignancy increases substantially. For patients with E antigen positive hepatitis B, there's a very steep step up in the risk of liver malignancy as you pass your 40th birthday. So most of us think that patients in their 40s and 50s with hepatitis B need a slightly different starting approach. As we get older, of course, we start to develop lots and lots of different comorbidities. Things start to ache, things start to get a little bit more challenging, and we start to find we're taking more and more medications. So your first question, when you're looking at someone who's a little bit older than your average hepatitis B patient, is what else is going on in their life, and how is that going to affect your approach to management? One of the things that isn't a major concern, of course, in the elderly patient is the issue of pregnancy, the issue of protecting children, and a lot of us are just that little bit nervous about starting antiviral therapy in women of childbearing years. Of course, as you get older, that consideration reduces completely. So given we've got a population where the relative soft contraindications to thinking about treatment, patient reluctance to think about medication is starting to ease as people get older, it is, I think, appropriate to take a slightly more progressive approach to antiviral therapy. So certainly in my practice, when I'm looking at patients in their 40s and 50s, I'm starting to think, do I really need to avoid therapy in this individual? We all have patients who are absolute certainties for treatment, people with high transaminases, progressive disease, high hepatitis B DNAs, and we all have patients who have very quiet disease, very low levels of surface antigen, undetectable DNA, perfectly normal transaminases, and perfectly bland histology or a normal FibroScan score. And of course, those extremes are always easy to manage. But it's that grey zone in the middle, the DNA levels of a few thousand, the ALT levels blipping up and down a little bit. And for many of us, we agonise about when's the right time to start those patients on treatment. For me, in the elderly patient population, I think the decisions are a little bit easier. I tend to push towards the early starting of treatment. And the reason for that is that, as we mentioned before, the risk of malignancy, the risk of progression is that little bit higher, and the relative contraindication of other things in their lives are much reduced. So my own view is that we should be starting to consider therapy in the light grey patients who are elderly, rather than waiting for them to move into the slightly more progressive phase. So once we've decided that our patient needs antiviral medication, we then need to think a little bit about what we're going to use and how we're going to administer it. There's a whole host of medications that people start to take as they get older, hypertensives, statins for their hyperlipidemia, and so on and so forth, all start to come into play. Most of the hepatitis B drugs that we use today have a very good drug-drug interaction profile, and there are very few drug-drug interactions that we need to be concerned about. But that shouldn't cause complacency. We should just keep a watch on what else our patients are taking. And if it's an unfamiliar drug, there are lots of websites that we can access to tell us whether or not there's likely to be an interaction, either for enhanced toxicity or for reduced efficacy. So when I see patients taking drugs that I'm not familiar with, I always check with our pharmacist or have a quick check online to make sure that I'm not missing a trick. As we age, I'm afraid, our Metabolic functions tend to decline, our kidneys start to get a little less robust, our bone health starts to deteriorate. And these are very important things to consider when you're looking at the therapeutic options in the elderly patient with chronic hepatitis B. Although the drugs have an excellent safety profile, they've been used for many, many years, there are some concerns with some of the agents about renal and bone toxicity. So it's always a good idea to look at the safer medications, those that are kidney friendly and those that are bone friendly. And certainly when I'm looking at patients with significant liver disease who have quite a significant risk of osteoporosis, I tend to do a DEXA scan before starting therapy just to give me a baseline. And in those patients, of course, it becomes very important to avoid drugs that have any risk of increasing bone absorption. It's important to remember the basics of hepatitis B, of course. Patients who are elderly are just as much at risk of transmitting to their partners. They're just as much at risk of transmitting to their children or grandchildren as younger people. So it's a very good idea to think about protecting the rest of the family, make sure they're up to date with their vaccinations, and make sure they've all been properly tested for hepatitis B. It's easy to assume that in that 55-year-old who's just been detected with hepatitis B, everything will have been done by the primary care physician and the family will have been tested and his children will have been assessed. I think that's a dangerous assumption, and bitter experience tells me that it's always a good idea to test the rest of the family and make sure they're properly immunised. We started by talking about the increased risk of liver malignancy in patients over the age of 40 or 50. And it's very important that we look at those patients with hepatitis B in the context of their other comorbidities and their cancer risk. Of course, as we age, our risk of diabetes increases, our sugar tolerance and our obesity risk starts to rise. So very important that we think about our cancer screening in the context of other pro-malignant phenotypes that are going on. So for me, I would be very aggressive in our liver ultrasound scanning. We make sure that everyone over the age of 40 gets a 6-monthly ultrasound scan and alpha-fetoprotein. And for those patients with diabetes, we perhaps start to think about doing it even more frequently, but we certainly want to be sure that those patients with obesity-related problems are getting a high-quality scan. And if that means an MRI scan, then so be it. So we've got our elderly patient. We've made sure that the family's protected. We've made sure that they're on a high-quality scanning program, and that they're aware of the reasons they're being scanned, so they know the importance of attending. And then we're going to start them on medication in the usual way. This is where we need to emphasize the compliance issue. Elderly patients often have a portfolio of tablets. It's very rare that they're just taking one, and we need to think a little bit about how we're going to ensure that that really important hepatitis B medicine is included in their daily routines. We use dosset boxes. Those are little boxes with special compartments. We can get our pharmacists to pre-package tablets labelled by the day so we can be sure that people with complex drug regimes don't forget the hepatitis B medication. And the beauty of the medications that we use for hepatitis B, of course, is that they're time agnostic. Most people prefer to take them early morning or late evening. It's funny how the lunchtime dose is the dose that always seems to be missed. But if you talk to your patient about what other medication they take, find out when they take the majority of their tablets and perhaps add the hepatitis B into that part of their day, so that as they brush their teeth in the morning, they take their blood pressure pill and their hepatitis B medication, and then they're set up for the day. Important, of course, to keep a gentle watch on response to therapy. The drugs that we have nowadays are so effective that if I see a rise in hepatitis B DNA, I don't think about resistance, which we never see. I think about compliance. And that's when we start to have a sit down and a little discussion with the patient. So to pull it all together, we need to evolve our clinical thinking as our patients age. Important to remember that with age brings not just wisdom, I'm afraid, but increased comorbidity and increased risk of complication. And in my view, patients as they age should be considered a little more progressively for antiviral therapy. And I'm much more enthusiastic about starting therapy in my 40 to 50-year-olds than perhaps in the 20-year-olds, where they're less likely to be compliant and they've got other things going on in their lives. And once you've started therapy, important to keep monitoring, important to use medication that isn't going to cause drug-drug interactions or influence other ongoing comorbidities, and of course important to check compliance by checking their hepatitis B DNA levels.
Thank you to Professor Foster for that excellent discussion, and thank you to our listeners for joining in. As a reminder, to view the full program on optimizing outcomes in older patients with HBV on the Clinical Care Options website, click on the link in the show notes for this episode. And please be sure to check back regularly for more episodes on important infectious disease topics. Thank you.